Hello, my name is Allison Littleford, a current BSN to DMP student at Pittsburgh State University, and today I'm going to tell you about a case study from my clinicals spent in our fast track or level 4 and 5 triaged patients in the ER at Bartlesville. This is a 34-year-old male that came to us via private vehicle and wheelchair once he got here. He presented to the emergency department with left ankle pain following a fall while walking on a trail. He fell from a standing height. He denied loss of consciousness. He slipped, hit his, kind of lost his balance and landed on his left ankle behind him, fell on uneven ground where there were some rocks off of the trail. There were no other complaints. He's a 34-year-old Caucasian male. He works in an office building. He went for a walk on his lunch break at the local trail that does have concrete and other terrain around it. He fell from the standing height, as I said previously, kind of landed awkwardly on his left ankle, was on a lower level with some bigger rocks, and he was unable to bear weight following the fall. He had a friend with him, and it was about 30 minutes prior to arrival. He rated his pain a 7 of 10. It was throbbing and constant. His friend was a volunteer firefighter, so he had some SAM splints, which is foam with really lightweight aluminum. So they did a stirrup splint and wrapped it with ACE wrap. He did not take any medication prior to coming. His past medical history is significant for obesity. He has a BMI of 33. He denies any other medical problems. He doesn't take any daily medications. He has no known drug allergies. He denies smoking, drinks alcohol occasionally, does not use street drugs. He does not take, like I said earlier, any medications. He does not see a primary care physician routinely, but he had lab work done a few years ago, and he said his glucose was right on the borderline, but everything else was normal, including his lipids. He has never had high blood pressure readings, although on triage his blood pressure was like 160 over 95, but he was also in a lot of pain. He has been increasing his physical activity to try and lose some weight and been walking briskly for 30 minutes on his lunch break every day for 5 days. A poor family historian for their past medical history, but his dad does have type 2 diabetes, hypertension, and hyperlipidemia. He does take 2 medications, for one for blood pressure and one for his cholesterol. His mother has history of hypothyroidism and hypertension. Maternal grandfather was deceased, history of coronary artery disease. Maternal grandmother was alive. She had history of cancer. He wasn't sure where, or what the history was, but she had been treated and has been in remission for quite some time. His paternal grandparents are both deceased, and he was unsure of their health history, although he thinks they both had diabetes, and one had heart failure because he knew that his grandfather had a lot of swelling, and both were heavy smokers. His review of systems were unremarkable, except for the bold positives here. So, denied weight loss gain, no vision changes, no headache, dizziness, postnasal drainage, denied chest pain, palpitations, shortness of breath. Was positive for left lower extremity edema, pain. He was unable to bear weight following the fall, and he did have what looked like an obvious deformity. He had some bruising starting and denied nausea, vomiting, or diarrhea. As you can see, I have documented the physical assessment. I'm going to do the focused exam to tell you what was abnormal. His spine was within normal limits. We did test and look to make sure he didn't have any other trauma. His extremities were positive for the left lower extremity had edema. It was his from about middle of shin down distally, he was swollen, very tight, was having some bruising already. His temperature was equal on both sides. He didn't have any coldness in the left affected extremity. He did have 2+ pulses, but even from the time that I first went in to going in to discuss plan of care later, he had increased swelling, and we had marked pulses because it was becoming more difficult to palpate. Initially, they were both 2+, and we were able to Doppler both as well, just in case the swelling got worse. He was unable to perform any physical exams with the the left lower leg as far as assessing distal or dorsal or plantar flexion, and he wasn't able to bear weight. Strength wasn't able to be tested in that as well. He also, upper extremities were all within normal limits. There were no abnormalities noted. Psychiatric, he was alert and oriented. He denied any loss of consciousness. His friend was at the park with him walking when he fell. He denied a loss of consciousness, lost his footing. It wasn't a risk for neurological, and everything was intact other than the musculoskeletal, which I discussed. So this patient had a 3-view minimum of the left ankle ordered in triage, and that was completed after our physical exam. So the results of his diagnostic imaging, unfortunately, I didn't copy his exact radiology reading because when I ended clinicals, I didn't know I was ending them. So I wish I would have, but he had a trimalleolar fracture. And I didn't really understand how complicated this was until we started reviewing the x-ray. And I knew he had an ankle fracture. I assumed that he would be seeing our orthopedic, probably having, an ORIF surgery, and go home non-weight bearing, or, depending on how significant the surgery was and what the surgeon said. So this is more complicated than I had realized. And, at triaging the patient, he was a level 4 and sent down to the fast track side, which is, your less complicated patients that require, one intervention or none. So this guy was a little more complicated than our typical fractures, which we either splint and send home, or consult ortho and set them up for outpatient. So this one we were not able to do that. So the treatment plan for this patient was consult the in-house orthopedic surgeon, which was Dr. S. So we paged him. It was about 5 minutes from the time we had results from radiology to the time we paged him. And he said, "Let me look at the images and I'll call you right back." Well, he called immediately back and said, "This is a traumatic fracture, and this is too complicated for what we do here. We don't do enough of them." And he discussed the widening of the fracture as well, and said he needed to go see the trauma surgeon in Tulsa. So again, I didn't print the exact readout of this patient. I wish I had, because I didn't know this is who I was going to do mine on. But I just knew that it was a trimalleolar fracture in the radiologist read, and I didn't understand the complications. So I was looking online for case studies, and it just discussed the alignment of the bone being one of the concerns, and then the widening space, and then the mechanism of injury and which approach you use. And it can be very complicated in this type of fracture, so they don't do that enough at our facility. So he was transferred to Tulsa to the trauma surgeon. So the next step was to call the transfer coordinator at Tulsa, and he was accepted immediately by the trauma orthopedic surgeon there. And then we discussed the plan of care with the patient. It was a closed fracture, so he didn't require immediate antibiotics. He didn't have any medications. We did treat his pain prior to transfer with a IV injection of fentanyl, 50 micrograms, and then we also gave him 4 milligrams of Zofran. And he didn't, the orthopedic surgeon in Tulsa didn't require any more testing. He just wanted him there to get him into surgery. So we discussed the plan of care with the patient. He signed consent for transfer, and we sent him on to Tulsa, which I did not see as an outcome for this patient when starting. So it was very interesting for me as, fast track provider to get to participate in assessing a patient and then getting him transferred with the transfer coordinator to Tulsa. I appreciate your time. Thank you.